Today we're going to look at some of the major physiological changes that occur during a normal pregnancy. And specifically, we're going to look at those maternal adaptations. We're first of all going to look at the circulatory system and how that changes. We'll then go on to the respiratory, the brain and the gastrointestinal changes, before finally touching on just a few of the endocrine adaptations that occur. Just remember, of course, that there are far more changes than that do actually occur than we're actually going to cover today. So when we're looking at the circulation, we obviously need to have a greater volume of blood present, and therefore that is theoretically going to lead to a greater cardiac output, because the growth of the fetus and the placenta requires extra nutrients, requires extra oxygen, and therefore requires extra blood vessels. And so we get an increase in our metabolic demand of the mother, and this is met by those hormone-driven physiological adaptations. And if we're looking at the average maternal weight gain, that's around about 12.5 kilograms. Half of that is the uterus, conceptus, and breast, and 3 kilograms is of fat, which are reserves in preparation for lactation, for example. And the circulatory adaptations, and that's what we're focusing on in this little session, the maternal plasma volume increases by about 40% between 6 and 30 weeks. And this is a little graph just showing the percentage of the non-pregnant level. So if you're looking at a non-pregnant level, that will be at 100%. And then we're looking at weeks of pregnancy. And those 3 red lines that you can see, so 1, 2, and 3, these refer to either the mean blood pressure over the course of the pregnancy, the cardiac output over the course of the pregnancy, or the systematic vascular resistance, so the total peripheral resistance, so how vasoconstricted or dilated the blood vessels actually are. And so what I'd like you to do is have a little look at this, have a little think, and think which one of those lines, those red lines, is related to the mean blood pressure changes, the cardiac output changes, or the systemic vascular resistance changes. So press pause, have a little bit of a think, and then we'll go through it. So first of all, cardiac output, that increases. We've got an increase in our plasma volume. That means we get an increase in our venous return, we get an increase in our cardiac output, heart rate goes up and contractility go up. So therefore our cardiac output does go up. Mean blood pressure. Blood pressure doesn't change very much at all, and that's because of progesterone-induced vasodilation. So even though there's an increase in our cardiac output, we get an increase in vasodilation, which means that we don't get a significant change in blood pressure. And of course, that means that our systemic vascular resistance, that tends to drop. And that's because of smooth muscle relaxation and vasodilation. And as we've mentioned, that is progesterone mediated. So the cardiac output, that rises by about the same amount as the plasma volume. So it goes up by about 40%. The mean blood pressure doesn't really change very much at all. A little bit of a drop towards the end of pregnancy, but it really doesn't change very much. And that's because the systemic vascular resistance drops. So we get progesterone-mediated vasodilation and smooth muscle relaxation. So again, a couple of little questions for you. So here are some of the changes in circulatory system that occur during pregnancy. We have an increased blood volume. Why? What happens to the heart size during pregnancy? What changes to our cardiac output? Well, we just covered that. So what happens? That's, as we said, that goes up by about 40%. And what changes to the heart position occur during pregnancy? So you're thinking about displacement due to the presence of the growing baby. So again, press pause and have a little bit of a think about what the purposes of each of these are. Well, if we're looking at an increase in the blood volume, this occurs because it helps to facilitate that maternal and fetal exchange of our respiratory gases, nutrients, and metabolites. But just as significantly, it reduces the impact of maternal blood loss at delivery. And the average vaginal delivery loses about 500 mils of blood, and a C-section, the average amount of blood loss is about 1,000 mils. So that helps to mediate or reduce the impact of that maternal blood loss. What happens to the heart size? Well, the chamber is enlarged by dilation and hypertrophy. And the dilation is occurring because of that increase in venous return, of course. So we're getting an enlarged left ventricular hypertrophy. What about the cardiac output? Well, as we've already said, during pregnancy, you do get an increase in your sympathetic activity. Heart rate increases by around about 15 beats per minute on average. Your stroke volume increases as well. And that, again, is due to the Starling's forces of the increased venous return and blood volume, as we've already mentioned. And therefore, what about the changes to heart position during pregnancy? Well, you get an upward displacement of the diaphragm by the enlarging uterus, which causes the heart to shift left and anteriorly. So we've said the elevated plasma volume increases because of the rapidly growing size of the uteroplacental vascular bed. We have more blood vessels being generated. This, of course, would generally lower the total peripheral resistance because there's a greater amount of vasculature, and therefore that would theoretically reduce the GFR. And this is what is happening, of course, as it's progressing. You get a reduction in our GFR. That, of course, then goes on to stimulate the renin-angiotensin-aldosterone system. And, of course, the renin-angiotensin-aldosterone system leads to an increase in aldosterone, an increase in sodium retention, an increase in water retention, and therefore increasing our blood volume. So that's one of the mechanisms for that increase in blood volume. It's further augmented, of course, by vascular smooth muscle tone inhibition by progesterone, because remember, during pregnancy, progesterone levels dramatically increase. And because progesterone decreases the vascular smooth muscle tone, it therefore decreases the total peripheral resistance. Estrogen activation, so we get an elevation in estrogen, and that activates nitric oxide synthase in our endothelial cells, and therefore we get an increase in nitric oxide release. And of course, nitric oxide is a potent vasodilator, again decreasing total peripheral resistance. And finally, the prostacyclins that are released by the placental endothelial cells, they also stimulate vasodilation, again leading to a decrease in our total peripheral resistance. So remember, that's all bringing together what we've been talking about, an increase in our cardiac output because of the increase in our blood volume. But we get blood pressure remains about normal during pregnancy because we're getting systemic vasodilation, so therefore reducing our total peripheral resistance. So, of course, the reduced total peripheral resistance lowers the pressure in the renal afferent arterioles. And as we said in the last slide, this reduces our GFR and that triggers renin release. And of course, that leads to aldosterone, which stimulates sodium and hence water reabsorption by the kidney, because remember, water follows the sodium. Estrogen also stimulates renin synthesis by the renal tubules and angiotensinogen synthesis in the liver. So all of these things together are going to increase our blood volume and blood pressure. So during our pregnancy, we get an increase in our progesterone, our estrogen, and our prostacyclins. That decreases our total peripheral resistance. That drop in total peripheral resistance leads to a drop in our GFR, which leads to a stimulation or an increase in our renin. Estrogen, of course, also stimulates renin synthesis. It also stimulates angiotensinogen synthesis. And of course, renin converts that angiotensinogen into angiotensin 1. Then we get conversion into angiotensin 2 through angiotensin converting enzyme. And that leads to the release of aldosterone, which of course leads to sodium and water reabsorption, elevating our blood volume and elevating the cardiac output. So those are the mechanisms behind, or the key mechanisms behind the changes. Remember, of course, that angiotensin 2 also stimulates thirst, it stimulates antidiuretic hormone release, and it stimulates sodium retention in the proximal tubules. So there are lots and lots of effects there. But also, just so that you're aware, because angiotensin 2 normally causes vasoconstriction, well, the blood vessels become less sensitive to angiotensin 2 during pregnancy, so there isn't as large a vasoconstrictive effect. It still has a vasoconstrictive effect, of course, but the blood vessels just aren't quite as sensitive. So progesterone, human placental lactogen, and prolactin all stimulate erythropoiesis. So remember, we've got an increase in our blood volume of 40%. We need to have some red blood cells in that 40% increase in blood volume. and that is being stimulated through these hormones. So we get a red blood cell increase by about 20 to 30%. Remembering, of course, that we got a 40% increase in our blood volume, but only a 20 to 30% increase in our red blood cell count. We also get an increase in our coagulation factors, such as fibrinogen and factor VIII. But that, of course, leads to an increased risk of pulmonary embolisms and DVTs because you've got a greater chance of coagulation occurring. So some of the real questions are about this. Why in pregnancy do women often get physiological anemia of pregnancy, as it's called? So have a little bit of a think. Well, of course, we get the dilutional effect. We get a 40% increase in our blood volume versus a 20 to 30% increase in our red blood cell count. So therefore, the red cell count, the hematocrit and hemoglobin levels all appear to be reduced due to that increase in blood volume. So in other words, the increase in erythropoiesis doesn't offset the rise in the blood volume. What about the coagulation factors? Why do they increase during pregnancy? Well, of course, coagulation factors are increased through the increased liver synthesis, and that's basically putting your body into a hypercoagulable state. And particularly because of the decreased ambulation in pregnancy and following birth, in particular if it's a C-section. So it's basically to help prevent excessive bleeding at delivery. Remember, quickly say to yourself, what are the volumes that you lose in an average vaginal delivery versus C-section? 500 mils vaginal, litre C-section, just roughly. So we've got an increase in our blood volume. We've got a decrease in our total peripheral resistance, but we do get a rise in our cardiac output. This drives increased blood flow to the uterus, to the breasts, and to the skin. And that increase in skin blood flow allows more heat loss due to our increased metabolic rate, and we get an increase in thyroxine synthesis during pregnancy. It's basically a reserve of thyroxine, but that helps to increase that metabolic rate because, of course, thyroxine regulates our metabolic rate. The gravid uterus, gravid just means pregnant. The gravid uterus can increase the pressure on the vena cava. What are the possible implications on the legs in this? Again, have a little bit of a think. Well, of course, it can start to restrict venous drainage from the leg. So pressure on the inferior vena cava can potentially release in varicose veins and edema within the feet, particularly occurring when it lies down. So it can potentially also damage the valves in the veins. And like I said, you get that edema in the feet because of the increase in that back pressure. What this does mean, because towards the end of pregnancy, you've got this gravid uterus, it's compressing that inferior vena cava. Towards the end of pregnancy, there may be a slight reduce in venous return, which might lead to a slight drop in cardiac output towards the end of pregnancy compared to earlier stages. So just go back and have a little look at that diagram at the beginning of this section, and you'll see there's a slight drop towards the end, but really it's not that significant in general. So, a review question for you. So, which of the following are correct regarding circulatory changes in a healthy pregnancy? Press pause, have a think. Number 1, blood volume is increased. That is correct due to activation of the renin-angiotensin-aldosterone system by estrogen. We get an increase in our angiotensinogen and renin levels as well, of course. Number 2, total peripheral resistance is increased. That's false. Total peripheral resistance is decreased due to the effects of estrogen, progesterone, and prostaglandin, which are leading to peripheral vasodilation. Cardiac output is increased. That is correct. So the increase in the blood volume and the decreased total peripheral resistance, we basically get to an increase in our venous return. We've also got that increased sympathetic activity during pregnancy. So we get about an increase in 40% blood volume, 40% increase in cardiac output, roughly. Number 4, blood pressure is increased. That's incorrect. It stays roughly the same because we've got an increase in blood volume and cardiac output, but a decrease in total peripheral resistance. They're basically offsetting each other. So the blood pressure in a healthy pregnancy stays roughly neutral. So we've covered the main circulatory adaptations that occur during pregnancy. We're now going to look at the respiratory, brain, and GI changes, gastrointestinal system changes. Let's all think about respiration. So progesterone, so you get high levels of progesterone during pregnancy. And progesterone has multiple factors, as you'll find out as we keep going through this session. But it acts on the hypothalamus to raise metabolic rates. So we get an increase in thyroxine, for example. And therefore, we get an increase in the maternal core temperature. So therefore, because of this, of course, we get an increase in oxygen consumption. It increases by about 15% during pregnancy. And this is facilitated by the increased oxygen carrying capacity of the blood. Remember, we had an increase in our red blood cell count. And during pregnancy, the functional residual capacity and the total lung capacity is reduced because of the displacement of the abdominal contents into the thorax. And so a lot of people will find exercise starts to get harder as pregnancy carries on and the gravid uterus gets larger and larger, and therefore displacing the lungs, of course, because displacing the abdominal contents into the thorax, meaning there's less space for the lungs to expand out into. In addition, progesterone also increases the sensitivity of the central chemoreceptors. And the central chemoreceptors, remember, are measuring CSF levels of hydrogen ions via carbon dioxide in the medulla. So pulmonary ventilation increases by about 40% but this is due to an increase in tidal volume. There isn't any significant change in breathing frequency. And what's happening is basically people are using, or pregnant ladies are using more of the inspiratory reserve volume. So here's your tidal volume. And basically during pregnancy, more of this inspiratory reserve volume is used, such that instead of breathing in 500 mils and breathing out 500 mils, you're breathing in and out about 700 mils is the new tidal volume during pregnancy. Remember, breathing frequency doesn't significantly change during pregnancy. If we're thinking about the GI tract, energy intake needs to increase, and this is by about 300 calories per day, or 1200 kilojoules, and that's by the end of pregnancy, so it's less at earlier stages. About a kilogram extra of protein is deposited, half a kilogram of protein to the fetus and placenta, half a kilogram to the uterine muscle, breasts, and the increase in plasma proteins. Progesterone also causes GI tone and motility reduction because it relaxes smooth muscle. So it relaxes smooth muscle everywhere. Okay, so it's causing that relaxation of the smooth muscle, which means, of course, that we get less GI tone and motility because of that. Therefore, we're getting an increased transit time through the GI tract. So basically, food residue stays in the GI tract for longer. And because it stays in there for longer, you get an increase in your water absorption. It may lead to constipation because there's increased water absorption and the food is staying there for longer. And because there's a prolonged gastric emptying time, it means you're more susceptible to reflux and heartburn. Finally, people often feel sick and vomit during the first trimester in particular. There are lots of hypotheses on what the mechanisms for this is, and one of the more common mechanisms is it's due to a rise in HCG levels, which of course are produced by the developing placenta, and the aim of HCG is really to maintain the corpus luteum of pregnancy in the early stages of pregnancy, therefore maintaining estrogen and progesterone levels before the placenta is fully developed. Of course, it's also recommended, if you're thinking about GI and nutrition, that roughly double the normal folate levels are required to help prevent neural tube defects. And during pregnancy, many women report an increased sense of calm and well-being. And that's because of the reduced neuroendocrine responses to stress during pregnancy. So some of the progesterone metabolites, so allopregnanolone, for example, enhances the sedative effects of GABA. And GABA is the brain's primary inhibitory neurotransmitter, basically functioning as an internally produced tranquilizer. But of course, after pregnancy, when progesterone levels plummet and estrogen levels plummet as well, allopregnanolone levels also plunge. And this is thought to be one of the mechanisms behind postpartum mood swings or depression. Of course, progesterone levels are also low before menstruation, and this leads to some of the symptoms associated with PMS, premenstrual syndrome, and those mood swings that some individuals suffer with. So, another set of review questions. So, which of the following are correct regarding the physiological changes in pregnancy? So again, press pause and have a little bit of a think about each of the questions. Number 1. Displacement of abdominal contents into the thorax reduces the inspiratory reserve volume of the lungs. That's incorrect. It reduces the functional residual capacity and therefore the total lung capacity. The inspiratory reserve volume remains roughly the same, and it's actually used, remember, to help increase the tidal volume from 500 to 700 mils. Number 2. Progesterone increases the sensitivity of central chemoreceptors to oxygen, therefore increasing tidal volume via respiratory centers in the medulla. That's incorrect. It increases the sensitivity of the central chemoreceptors to the hydrogen ions that are thought to be the receptor in those central chemoreceptors. And remember, the hydrogen ions are produced because of the increase in CO2 diffusing across into the CSF. Number 3. Progesterone reduces gastric emptying time and GI motility, therefore causing potentially constipation and acid reflux. That's incorrect. It increases the gastric emptying time, which can lead to reflux and potentially constipation. In other words, the food is staying there for longer. Number 4. Morning sickness is caused by elevated HCG released from the developing corpus luteum. That is also incorrect. Remember, HCG is released from the developing placenta to maintain the corpus luteum of pregnancy, which is releasing estrogen and progesterone, of course. So the last little section we're going to go through in the physiological changes are some of the endocrine adaptations that occur during pregnancy. So, first of all, if we're thinking about the pituitary gland of the mother, the maternal pituitary increases in size by up to 50% during pregnancy. It's largely due to an increase in a variety of hormones. So, for example, there's quite a significant increase in the levels of prolactin. Prolactin has multiple roles. Okay, and one of those roles, of course, is to stimulate milk synthesis, but it also helps in the development of the breast. We also get an increase in oxytocin, and remember that's from the posterior pituitary, and ACTH, adrenocorticotropic hormone synthesis, that is from the anterior pituitary. So what does oxytocin do? Well, we know that oxytocin stimulates smooth muscle contractions. So, for example, it stimulates uterine contractions during labor and milk ejection during suckling. We get an increase in synthesis, but it is stored in the posterior pituitary, hence one of the reasons why the pituitary gets a little bit bigger. And oxytocin release is stimulated by multiple factors. So during parturition, so just during childbirth, we get an increase in our estrogen levels. That stimulates the release of oxytocin. Cervical stretch prior to and during parturition, also that's activating mechanoreceptors, which stimulates oxytocin release. And oxytocin is also released during the suckling reflex. So when the newborn baby is suckling on the nipple, that's stimulating mechanoreceptors, which go to the hypothalamus and activates the hypothalamic posterior pituitary axis to release oxytocin. Oxytocin also stimulates the release of prostaglandins, and they help to stimulate uterine contractions. So if we're looking at this whole pathway, which is shown on this right-hand side, you get the release of oxytocin, and that in itself is stimulated by uterine contractions, and the increased stretch because of uterine contractions has a positive impact, a positive feedback loop. And likewise, oxytocin stimulates that smooth muscle contraction, which again is a positive feedback loop, We also get, as we've mentioned, the prostaglandin release as well. Progesterone stimulates a 20-fold increase in prolactin secretion. So we have an increase in our progesterone during pregnancy. That leads to an increase in prolactin. That leads theoretically to an increase in milk synthesis. But the increased estrogen and progesterone during pregnancy actually has an inhibitory effect on milk synthesis. So in other words, we get an increase in progesterone, which makes prolactin be increased. That would usually drive milk synthesis, but progesterone and estrogen actually during pregnancy inhibit that milk synthesis. So what does the prolactin do? Well, along with progesterone, it helps in mammary gland enlargement and helps to prepare for milk production. So what stimulates milk synthesis and secretion after birth? If we're thinking we're not getting that milk synthesis because progesterone and estrogen are inhibiting it, what is actually driving milk synthesis? Well, it's the rapid drop in estrogen and progesterone at birth that allows prolactin to therefore go on to stimulate milk synthesis. And the suckling that the baby does stimulates the mechanoreceptors in the nipple, which stimulate both prolactin, so therefore milk synthesis, and oxytocin, which is milk secretion, so contraction of myoepithelial cells, to allow more milk to be produced for the baby to suckle, who then continues in that positive feedback loop until the baby is full and no longer suckles. And oxytocin that is released during breastfeeding in the first few weeks following birth often actually causes painful contractions of the uterus, because remember, it stimulates smooth muscle contraction. And remember, the uterus has got plenty of muscle still there. But it does also help with involution of the uterus, so that's shrinkage of the uterus back to its original size. So therefore, we're seeing that progesterone and prolactin are involved in breast development. Estrogen is also involved, and so is HPL, human placental lactogen. So another thing that's released is corticotrophic releasing hormone. So CRH is released from the developing placenta, and that stimulates that ACTH secretion from the maternal anterior pituitary. Now, that then goes on to stimulate cortisol secretion, because that's part of the link. CRH from the hypothalamus usually, but now from the developing placenta. Stimulates ACTH from the anterior pituitary, which goes to the adrenal cortex to stimulate the release of cortisol. And cortisol downregulates insulin receptor synthesis. So in other words, what it's doing is reducing the number of insulin receptors that are present. So we have an increase in our ACTH, which leads in itself to increased pigmentation around the areolae of the nipples, because ACTH has melanocyte stimulating activity. So it can, in these high amounts, it can stimulate the melanocytes to produce melanin and therefore increase that pigmentation. It leads to an increase in cortisol, and cortisol reduces or inhibits collagen synthesis by fibroblasts, and that can lead to abdominal striae, which look like stretch marks. And it's also potentiated by its proteolytic effects, because cortisol stimulates proteolysis as well. But as we said, cortisol downregulates insulin receptor numbers. That basically is leading to insulin resistance, so we're therefore getting an increase in our maternal blood glucose levels, which is a very useful thing because it increases glucose delivery to the fetus. But of course, that insulin resistance enhances the diabetogenic effect of pregnancy, in particular in women who are overweight or obese, who have inherent insulin resistance already present, or who may be diabetic already, type 2 diabetic. So it enhances the probability of gestational diabetes mellitus. The thyroid gland also increases in size during pregnancy. And that's because HCG has high homology to TSH and stimulates thyroxine release. And that goes on to bind to plasma proteins, in particular thyroxine binding globulin, which has actually been stimulated to increase in amount by estrogen. So basically, estrogen stimulates the synthesis of thyroxine-binding globulin, which binds most of the extra thyroxine that is being stimulated to be produced because of the increased levels of HCG, which has got thyroid-stimulating hormone similarities, homology. So your developing placenta produces HCG, we all know that. That stimulates the thyroid gland to produce thyroxine, also called T4 and T3. That then moves to the fetus and helps to enhance growth and central nervous system development. And the maternal bound thyroxine basically is acting as a reservoir to supply the fetus and help regulate its growth and its metabolic rate. Finally, we're just going to talk about calcium, and you have PTH-RP. Now, PTH stands for parathyroid hormone. PTH-RP is parathyroid hormone related peptide. It was originally thought to be produced only from certain types of cancers because it's not detected in the blood in healthy adults or children. However, it is known to be secreted in pregnant women and in some healthy adults and in healthy adults, but it acts in an autocrine and paracrine way, and therefore we don't detect it in the blood in healthy adults, like I said, but we do see it in pregnant women. And it helps to increase calcium transport from the mother to the fetus. And these mechanisms helps to ensure that the fetus is well supplied with calcium. But of course, it does reduce maternal calcium levels. So when calcium levels or calcium intake is inadequate in the mothers, we do start to get mobilization of calcium from the bone, and that's predominating, and that does help to contribute, or it contributes to the increased risk, for example, of dental caries in the third trimester of pregnancy. And if we're thinking about what usually happens, so this is again a little bit of the endocrine system, thinking about how calcium levels are regulated. You may have low calcium levels. That stimulates the parathyroid gland, of course, to release parathyroid hormone. Parathyroid hormone acts on the kidneys, and it helps with calcium absorption, so we don't urinate out as much calcium. Phosphate is also reabsorbed. That increases the plasma calcium levels. It also acts on the bone to lead to bone resorption, again increasing calcium and phosphate levels. And in the kidney, parathyroid hormone activates vitamin D, and that vitamin D, of course, leads to calcium and phosphate absorption from the small intestine. So you can see how this whole system is integrated together. But the key point here is that PTH-related peptide is released during pregnancy in a hormonal way, so it enters the blood rather than in healthy adults where it acts as autocrine and paracrine system. And it helps to increase calcium transport from the mother to the fetus. So, last little side, some review questions for you. So, which of the following are correct regarding physiological changes in pregnancy? Okay, so number 1, displacement of abdominal contents into the thorax reduces total lung volume. That is correct. Number 2, insulin resistance is normal during pregnancy, but is not normal in non-pregnant women. That's also correct. Remember, insulin resistance in pregnancy occurs because of the increase in CRH from the placenta, means there's more ACTH from the anterior pituitary, decrease in the insulin receptor numbers, leading to insulin resistance and an increase in the maternal blood glucose levels, which can then be delivered to the developing fetus. Number 3, progesterone reduces GI motility, therefore potentially causing acid reflux. That is also correct. Number 4, progesterone secreted during pregnancy increases prolactin levels, leading to milk production prior to birth. That's incorrect. So whilst there may be some leakage of milk towards the end of pregnancy, milk synthesis is inhibited due to the very high levels of estrogen and progesterone.